assessment and diagnosis. Injury evaluation is a process. We look at the signs and symptoms. The signs and symptoms are used to determine the extent of injury. Symptoms are information provided by the injured person regarding their perception of the problem. Some examples of symptoms may include things like blurred vision, ringing in the ears, fatigue, dizziness, nausea, headache, pain, weakness, or the inability to move a body part. A diagnostic sign is an objective, measurable physical finding. Usually this is done by the clinician. A sign could be what the evaluator hears, feels, sees, or smells when assessing the patient. Prior to assessing any injury, the non-injured body part should be assessed. This serves to establish a reference point to help determine the relative dysfunction or injury to the body part. It can also be used as a reference point to help determine the extent of the injury. Typically, assessment of the non-injured part should precede the assessment of the injured part, but in some acute injuries, such as fractures or dislocations, the assessment of the non-injured part is not really necessary. Injury evaluation processes should include several key components, such as taking a history of the current condition, visually inspecting the area for noticeable abnormalities or differences, physically palpating or touching the region for abnormalities, and completing functional or stress tests. Two of the most common are the HOPS format and the SOAP note format. Each format has its advantage, but the SOAP note format is much more inclusive of the entire injury management process. So someone sustains an injury. How do we know how serious it is? First, we must investigate. Let's do a little digging. So let's start the injury evaluation process in 3, 2, 1. Starting our evaluation process. So following the objective evaluation, the examiner analyzes and assesses the individual's status and prognosis, or what we think their outcome should be. A definitive diagnosis may not always be known. However, the suspected site of injury, involved structures, and severity of the injury should be documented if we can. We should also look for long-term and short-term goals. Long-term goals reflect the anticipated status of the individual after a period of rehabilitation. Some examples might be pain-free range of motion, bilateral strength gains, so that we have the same strength on one side as we do the other. We could also have similar power measurements, muscular endurance measurements, cardiovascular endurance, or even return to full functional status. Our short-term goals should outline the expected progress within days of the initial injury. Some possibilities for short-term goals include the immediate protection of the injured area and control of inflammation, bleeding, muscle spasm, or pain. Both the long-term and the short-term goals should be updated with each progress note. A progress note may be written daily, weekly, or bi-weekly to document the progress the individual is making. We should also have an action plan. The action plan should include the following information: the immediate treatment given to the injured individual, the frequency and duration of expected treatments, including therapeutic modalities and therapeutic exercises, which we'll touch on in future chapters, the evaluation standards to determine progress towards goals, the ongoing patient education, and the criteria for discharge or return to play. Identifying the history of injury can be the most important step in the injury assessment. History can provide possible reasons for the symptoms. The history also allows us to identify possible injured structures prior to initiating the physical examination. A medical history file can be an excellent resource for identifying past injuries, subsequent rehabilitation programs, and any factors that could predispose the athlete to further injury. Documenting the history involves asking appropriate questions and also requires establishing a professional and comfortable atmosphere with your patient. There are potential obstacles sometimes in taking a history, including sociocultural dynamics between the patient and the clinician, which may hinder communication. As a clinician, we must understand and respect different cultural groups' attitudes, beliefs, and values related to health and illness. The history begins by gathering general information, such as the individual's name, gender, age, date of birth, occupation, and the activity in which the individual was participating when the injury occurred. When possible, convert subjective information into quantifiable data. This means it has some sort of number. This can correlate with the described symptoms. For example, when asking about pain, you can ask the individual to rate the severity of the pain using a scale from 1 to 10, with 10 being the most severe pain they've ever experienced, meaning that we need to go to the hospital right away. Although the intent of the history is to narrow the possibilities, it should always be taken with an open mind. If too few of factors are considered, we may reach a premature conclusion and fail to adequately address the severity of the injury. The evaluator must realize that the individual may not want to carry on a lengthy discussion or may trivialize the extent of the pain or disability. We must be patient and keep questions simple and open-ended. Pay close attention to the words and the gestures. Nonverbal communication is very important and may provide clues as to the quality and the intensity of the symptoms. It is essential to document in writing the information obtained during the history. We need to make sure that we're documenting our primary complaint, the mechanism of injury, the characteristics of the symptoms, the disability resulting from the injury, and any other pertinent related medical history. The primary complaint. Questions should be phrased to allow the individual to describe the current nature, location, and the onset of the condition or injury. Questions such as, why are you here? What is the problem? Where does it hurt? And what activities or motions are weak or painful? Sometimes the tone and inflection of our voice can change a question. The mechanism of the injury is probably the most important information gained in the entire history process. It is important to visualize potentially how the injury occurred to help identify possible injured structures. Asking questions like, how did the injury occur? Did you fall? If so, do you remember how you landed? Were you struck by an object or another individual? If so, in what position was the involved body part, and what direction did the force come from? Did you hear or feel anything during the injury? How long has the injury been a problem? And have there been any recent changes in running surfaces, shoes, equipment, techniques, or conditioning modes? It is important to visualize how the injury occurred to help identify possible injured structures, which will help direct the objective evaluation process. Primary complaint must be explored in detail to help discover the evolution of symptoms, including the location, onset, severity, frequency, duration, and limitations caused by the pain or disability. We're going to ask questions, this time about the location, onset, nature, severity, frequency, and duration of the pain. We can ask questions like, where does it hurt the most? Can you point to a specific spot? If we ask people to point to a specific spot, you might want to be specific in your instructions. Use one finger and point to the part that hurts the most. Is the pain limited to that area, or does it move to other parts of your body? On a scale from 1 to 10, with the 10 being the most severe, how bad is your pain? Can you describe the pain? Is it dull, sharp, aching? Can you think of other words for this? In chronic conditions, the following questions should be asked. When does the pain begin? When you get out of bed, while sitting, while walking, during exercise, or maybe even at night? How long does the pain last? Is the pain worse before, during, or after activity? What activities aggravate or make the symptoms better? Does the pain wake you up at night? How long has the condition been present? Has the pain changed or stayed the same? In the past, Were there any medications, treatments, or exercise programs that helped improve the symptoms? Pain can tell us a lot about the injury. We have somatic or visceral pain. Somatic pain may be deep, which sometimes presents itself as diffuse or nagging with possible stabbing pain and is typically longer lasting. This may indicate injury to a bone, internal joint structure, or even a muscle. Or somatic pain can be superficial, which more often presents itself as a sharp prickly with brief duration pain. This may be something like injury to the skin. We can also have visceral pain, which is a deep, nagging, and often pressing pain. This may be accompanied by nausea and even vomiting. This may indicate injury or damage to an internal organ, and we may even have referred pain, which is pain that radiates into other areas of the body. It may travel up or down the entire length of the nerve. In the English language, there are a lot of words that we use to describe pain. Here is a list of words that have been identified to describe painful situations. There are 78 words on this list. It's hard to believe. Some of these descriptions of pain sound absolutely awful, such as beating, lancing, gnawing, scalding, suffocating, penetrating, and torturing. Visceral organs can refer pain to specific cutaneous or skin areas. Some visceral pain travels along the same nerve pathway as some somatic pain. This is perceived by the brain as somatic in origin, meaning the injury is in one region, but the brain considers it in another. For example, when an individual has a heart attack and feels pain in the chest, left arm, and sometimes even the neck. Or an individual who has low back problems may feel the pain down the gluteal or the buttock region and into the back of the leg. Sometimes there is a disability resulting from the injury. In our evaluation, we should attempt to determine the limitation of the individual due to pain, weakness, or disability from the injury. Questions should not be limited to sport and physical activity, but should also include whether the injury has affected the patient's job, school, or activities of daily life, or ADLs. Related medical history questions can help us obtain information regarding other conditions that may affect this injury. Our pre-season physical examination may help to verify some of this information. Previous injuries or congenital abnormalities may predispose individuals to certain injuries. A healthcare professional should ask the individual if they are taking any medication. Know that the type of medication, frequency, dosage, and effect of the medication may mask some symptoms, so it's important to ask about medications. Observation and inspection begin the objective evaluation in an injury assessment. Observation is the visual analysis of the overall appearance, symmetry, general motor function, posture, and gait of an individual. Sometimes the observation is also called the inspection, in which we're looking for factors seen at the actual injury site, such as redness, bruising, swelling, cuts, scars, or deformities. The observation begins the moment the injured person is seen and continues throughout the assessment. Initially, assess the individual's state of consciousness and body language, which may indicate pain, disability, fracture, dislocation, or many other conditions. Please take note of the individual's general posture. Do they have a willingness to move or even an ability to move? Is there ease in their motion and their general overall attitude? Use discretion in safeguarding the individual's privacy, but if you can, the injured area should be fully exposed. Try to scan the body visually to detect any congenital, which means it's existing at birth, or functional problems which may contribute to the injury. If it's not contraindicated, which means it's against medical guidelines, observe the normal swing of the individual's arms or legs during walking. Observe from all angles if you can. Perform a scan to examine and assess the general motor function. Observe individuals doing gross motor movements in the trunk, neck, and extremities. Our observation and inspection. The inspection. These are factors that are actually seen at the injury site. In the inspection, the localized injury site is inspected for deformity, swelling, which could be edema or joint effusion, discoloration, which is redness, pallor, bruising, or ecchymosis. Also look for signs of infection, which would be redness, swelling, pus, red streaks moving towards the heart, or even swollen lymph nodes. Scars that may indicate previous surgery, general skin conditions. When we're looking at swelling, there's two different types of swelling. There's joint effusion and ecchymosis. Joint effusion is swelling inside the joint. It's due to localized interarticular swelling, making the joint appear enlarged, red, and puffy. The amount of swelling should be measured in a quantifiable manner using girth measurements. Ecchymosis is the discoloration or swelling outside of the joint in the surrounding soft tissue due to a bruise or other injury under the skin. When possible, we would like to use a bilateral comparison. For example, in the picture, we have LeBron James's hands. We have his right hand and his left hand. We can see that the right hand is a little bit more swollen, and there's a possibility that he actually had a fracture in this hand when he was playing. The next step in our injury evaluation is palpation. Prior to contact or touching the person, permission must be granted to the clinician to touch the patient. Our bilateral palpation should include things like skin temperature. An increase in skin temperature could indicate inflammation or infection. Decreased temperature could indicate a reduction in circulation. Swelling can be diffuse or localized in a small area. If swelling is inside a joint, motion will often be limited because of congestion caused by extra fluid. Possible fractures can be assessed with percussion or vibrations through the use of a tuning fork, compression, and distraction. Point tenderness and crepitus, which is a crackling sensation, sometimes referred to as snap, crackle, or pop, may indicate a fracture when felt over a bone, as the two ends of the bone are rubbing together, creating a grating noise or sensation. Point tenderness may indicate inflammation when felt over a tendon, bursa, or joint capsule. Note any trigger points that may be found in a muscle, and when palpated, refer pain to another site. Assess the differences in the density or the feel of soft tissues, which may indicate muscle spasms, a hemorrhage, edema, scarring, myositis ossificans, or other conditions. Check for cutaneous sensation. This can be tested by running the fingers along both sides of the body part and asking the patient if it feels the same on both sides. This can determine possible nerve involvement, particularly if the individual has numbness or tingling in the limb. Also check peripheral pulses. These are taken distal to the injury to rule out damage to a major artery. Some common sites would include the radial pulse of the wrist and the dorsal pedis pulse at the dorsum of the foot. As we're palpating, we want to make sure that we're touching an individual using gentle circular pressure, followed by a gradual deeper pressure. We want to begin away from the injured site and move towards the injury, being careful not to press too hard. Possible fractures can be assessed with percussion or vibrations through the use of a tuning fork, compression, and distraction. Some different methods of checking for fracture include axial compression. We are compressing the bone together. We could also have circular compression, where we're squeezing the bones together. We may also have distraction of the bones, or pulling them away from each other. We could also use percussion, which is where we tap near the site of the injury to see if the vibrations from the tapping cause pain as the bone ends vibrate together. Or we could use the vibrations from the tuning fork. The vibrations from the tuning fork will cause pain when the fractured bone ends vibrate against each other. When the tuning fork is hit, it actually causes the two ends of the tuning fork to vibrate. So when we press it on the individual, the vibrations are felt in the bone. During the physical examination tests, we can do functional testing. This objectively measures the body using a goniometer. A goniometer is a protractor with two rigid arms that intersect at a hinged joint. This is used to measure both the joint position and the available joint motion. The arms of the goniometer measure from 0 to 180 degrees of motion, or 0 to 360 degrees of motion. Measurements are obtained by placing the goniometer's stationary arm parallel to the proximal bone. The axis of the goniometer should coincide with the joint's axis of motion, and the moving arm is then placed parallel to the distal bone, using specific anatomical landmarks as points of reference. Unless contraindicated, active range of motion, meaning the patient is moving themselves, should always be performed before passive range of motion, meaning that the clinician is moving the patient. Active range of motion indicates a willingness on the patient's part and the ability to move the body part. This determines possible damage to contractile tissues, such as muscle, the musculotendinous junction, the tendon, and the tendon-periosteal union. Limitations in motion may result from pain, swelling, muscle spasm, muscle tightness, joint contractures, nerve damage, or mechanical blocks, such as a loose body in the joint. If the individual is unable to perform all active movements at the injured joint because of pain or spasm, then passive movement can be performed, meaning the clinician is moving the body part through range of motion with no assistance from the injured individual. As passive range of motion is performed, the individual should be positioned to allow the muscles to be in a relaxed state. Passive range of motion helps us to distinguish injuries to contractile tissues from non-contractile or inert tissues. Inert tissues such as bone, ligament, bursa, joint capsule, fascia, dura mater, and nerve roots. If no pain is present during passive range of motion, but is present during active range of motion, then the contractile tissue is injured. If passive range of motion is painful and there is a limitation in the movement, then the non-contractile tissue is injured. At the end of range of motion, a gentle overpressure is applied to determine infeels. Overpressure is repeated several times to determine whether pain increases, which could signify damage to non-contractile joint structures. The infeel can determine the type of disorder. 3 normal infeel sensations and 4 abnormal infeel sensations could be present. The muscle weakness and pain indicates a muscular strain. Muscle weakness in the absence of pain may indicate nerve damage. A brake test is an overload pressure test applied with the joint in a neutral or relaxed position. This helps to relax the joint structures and reduce joint stress. The limb is stabilized proximal to the joint to prevent other motions from compensating for weakness in the involved muscle. Resistance is provided distally on the bone to which the muscle or muscle groups attach and should not be distal to a second joint. For example, to test the strength in the elbow flexors, we're going to flex the elbow to 90 degrees, stabilize the upper arm against the body, and the patient is instructed to keep the arm in this position as the examiner applies a downward overpressure on the distal forearm. The pressure should be held for at least 5 seconds and repeated 5 to 6 times to indicate muscle weakness and/or the presence or absence of pain. A standardized grading system can be used to measure muscle contraction, but the results are negated if the contraction causes pain. Age and gender may influence range of motion. Women in their teens and early 20s tend to have the greater range of motion in all planes compared to men. Range of motion decreases after age 20 in both genders, with the decrease occurring to a greater extent in women. The normal range of motions for selective joints are shown here. We can also use stress tests. These allow us to assess the ligamentous and capsular testing in the body. Each body segment has a series of tests to help assess the joint function and the integrity of joint structures. These tests help us assess non-contractile tissues, such as ligaments, interarticular structures, and joint capsule stability. They also demonstrate impingement signs, muscle balance, and vascular integrity. Laxity is the amount of give within a joint's supportive tissues. Instability is the joint's inability to function under the stresses encountered during functional activities. It is essential to perform the test at the proper angle because a seemingly minor change in a joint angle can significantly alter the laxity of the tissue being stressed. During an on-site assessment, tests to determine the possibility of fracture and major ligament damage at a joint should always be performed before moving an individual. Special tests have been developed for specific body parts or areas to detect injury or related pathology. Special tests generally occur across multiple planes and are not graded. For example, Thompson's test, which is the test in the picture, is used to assess the integrity of the Achilles tendon. When we squeeze the calf with the foot off the table, then the foot usually goes down, like it's pressing on the gas pedal in a car. If the Achilles tendon has been ruptured, then the foot would not move, and this would be seen as a positive test. The positive test indicates that it's likely that the Achilles tendon has been damaged. We also have neurological testing. A segmental nerve, or the portion of the nerve originating from the spinal cord, is referred to as a nerve root. Most nerve roots share at least two components. There's a somatic portion and a visceral component. The somatic portion innervates a series of skeletal muscles and provides sensory input from the skin, fascia, muscles, and joints. The visceral component is the part of the autonomic nervous system, or ANS, and supplies the blood vessels, dura mater, periosteum, ligaments, and intravertebral discs, among many other structures. The motor component of a segmental nerve is tested using myotome testing, which is a group of muscles primarily innervated by a single nerve root. The sensory component is tested using a dermatome testing, which is an area of skin supplied by a single nerve root. Injury to a segmental nerve root will often affect more than one peripheral nerve and will not demonstrate the same motor loss or sensory deficit as an injury to a single peripheral nerve. Dermatomes are sensitivity that are assessed by touching the person with a cotton ball, a paper clip, the pads of the fingers, or even fingernails. We ask the individual about the sensations that are being experienced. It is important to determine the nature of the sensation. Is it sharp or is it dull? And to assess whether the same sensation was experienced in testing the uninjured body segment. Hypoesthesia is a decreased tactile sensation. Hypoesthesia is an excessive tactile sensation. Anesthesia is a loss of sensation, and paresthesia is characterized by a numbness, tingling, or even a burning sensation. Nerves can be injured from tensile and compressive forces. When a nerve is damaged, it can result in either motor or sensory deficits, or even both, meaning that we lose the ability to either move parts of our body or feel parts of our body, or even both. The cutaneous sensation patterns of the spinal nerve dermatomes differ from the patterns innervated by the peripheral nerves. The sensory component is tested using dermatomes. A dermatome is an area of the skin of the human anatomy that is mainly supplied by branches of a single spinal sensory nerve root. The sensory nerves in the periphery of the body are a type of nerve that transmits signals from sensation, for example, pain symptoms, touch, and temperature, to the spinal cord from specific areas of our anatomy. Myotomes, the majority of muscles, receive segmental innervation from two or more nerve roots. However, selected motions may be innervated predominantly by a single nerve root, or a myotome. Resisted muscle testing of a selected motion may determine the status of that nerve root. Weakness in the myotome indicates a possible spinal cord nerve root injury. Weakened muscle contractions may indicate partial paralysis or paresis of the muscle. In a peripheral nerve injury, there is a complete paralysis of the muscles supplied by the nerve. For example, if the L3 myotome is tested with knee extension, if the L3 nerve root is damaged at its origin in the spine, then there is a weak muscle contraction because the quadriceps muscle also receives nerve root innervation from L2 and the L4 segmental nerves. If the peripheral femoral nerve, which contains the segments of L2, L3, and L4 is damaged proximal to the quadriceps muscle, then the muscle cannot receive any nerve impulses and will be unable to contract to execute knee extension. Here's a list of the myotomes that are used to test selective nerve root segments in the body. Reflexes can indicate the presence of nerve root damage. The most familiar stretch reflex is the knee jerk or patellar reflex, performed by tapping the patellar tendon with a reflex hammer, causing an involuntary knee extension movement. Most of us have had this done at one point or another when we visited the doctor's office. Our reflexes, we have deep tendon reflexes, or DTRs. These assess damage to the central nervous system. Reflex testing is limited as not all nerve roots have a deep tendon reflex. Deep tendon reflexes tend to be diminished or absent if the specific nerve root is damaged. Exaggerated, distorted, or absent deep tendon reflexes indicate degeneration or injury in specific regions of the nervous system. They may be demonstrated before other signals are apparent. Abnormal deep tendon reflexes are not clinically relevant unless they are found with sensory or motor abnormalities. We also have superficial reflexes. These reflexes are provoked by superficial stroking, usually with a moderately sharp object that does not break the skin. This action produces a reflex muscle contraction. The absence of a superficial reflex indicates a lesion of the cerebral cortex of the brain or an upper motor neuron lesion. We also have pathological reflexes. These may indicate upper motor neuron lesions if bilateral or lower motor neuron lesions if they're unilateral, meaning they're only happening on one side. The presence often serves as a sign of some significant pathological condition. Motor function is assessed with manual muscle testing or resistive range of motion throughout a full range of motion. We may have sensory deficits that are assessed identical to dermatome testing, except for the cutaneous patterns differ. Special compression tests may be used on nerves that are close to the skin, for example, the ulnar and the median nerves. We have some special tests. One example is Tinel sign, which is performed by tapping the skin directly over a superficial nerve. A positive sign indicates irritation or compression of the nerve and would result in a tingling sensation traveling into the muscle and the skin supplied by the nerve. Activity-specific tests involve the performance of an active movement typical of the movements executed by the individual during sport or activity participation. In the rehabilitation process, the individual initially performs these skills at low intensity and increases intensity as the individual's condition improves. For example, someone who sustained a lower leg injury, we may test them by assessing first walking, then jogging, and then running forward and backward. If these skills are performed pain-free and without a limp, then the individual might be then asked to run in a figure 8 or a zigzag pattern. Again, each test must be performed pain-free and without a limp. Measurements should assess strength, agility, flexibility, joint stability, endurance, coordination, balance, and sport-specific skill components. The certified athletic trainer or medical physician often recognizes a possible injury or illness based on their assessment and, as needed, may refer the individual for further assessment. Various forms of laboratory tests and imaging techniques may be used by the physician to assist in making their diagnosis. The sports medicine team members should have a basic understanding of the purpose of these tests. Radiographs are the most common imaging technique. It provides an image of certain body structures. A myelogram uses an opaque dye that is introduced into the spinal canal through the lumbar puncture. A myelogram may identify pathologies of the spinal canal, for example, tumors, nerve root compressions, and disc disease. An arthrogram is an opaque dye, air, or a combination of the two that is injected into a joint space. An arthrogram can detect capsular tissue tears and articular cartilage lesions. A CT scan or a computed tomography scan can reveal abnormalities in bone, fat, and soft tissue. It produces a 3D cross-sectional picture of a body part. CT scans are relatively safe because there's very little radiation exposure during the procedure, but it yields a high detailed result. It is an excellent tool for detecting tendinous or ligamentous injuries in varying joint positions. Magnetic resonance imaging, or MRI testing, is an excellent tool for visualizing the central nervous system, spine, and musculoskeletal or cardiovascular systems. An MRI can help reveal soft tissue differentiation, for example, an ACL tear in the knee. It also helps us identify space-occupying lesions in the brain, such as a tumor or a hematoma. We can also assess joint damage, such as meniscal tears or osteochondral fractures. We can view blood vessels and blood flow without the use of a contrast medium, which can help us assess cardiac function. In many cases, the MRI has replaced the myelogram and the arthrogram. A radionucleotide stenograph, or a bone scan, can help to diagnose a stress fracture, as is seen on this X-ray in the yellow circle. It may be clinically correlated to the plain X-rays or other diagnostic tests. A bone scan can detect stress fractures of the long bones and the vertebrae, also detecting degenerative diseases, infections, or tumors of the bone. There's no special preparation needed prior to a bone scan, and the risk to the patient is extremely minimal. Ultrasonic imaging, sometimes called stenography, uses sound waves to view the various internal organs and certain soft tissues. An ultrasound is commonly used to monitor the development of the fetus during pregnancy. Electromyography can detect certain muscular conditions, such as deinnervated muscles, nerve root compression injuries, and other muscle diseases. At the end of our injury evaluation, the most important part is documentation. Documentation should be required to maintain accurate medical records. If you didn't write it down, it never happened. The Health Insurance Portability and Accountability Act, or HIPAA, requires specific documentation principles be followed so we can maintain our patients' confidentiality. The purpose of the documentation is to enhance communication, facilitate the continuity of care, and provide evidence of services for billing and legal protection. There's 8 basic principles of documentation. Number 1, we need to use the correct medical terminology. Number 2, we only use standard medical abbreviations. Number 3, we use correct punctuation. Number 4, we need to be accurate. Number 5, maintain brevity. We're not writing a novel. We need to write something that we can quickly refer back to, so it needs to be detailed, but it doesn't need to be 1,000,000 pages long. Number 6, write or type legibly. Number 7, documentation should be completed and filed at the time the services are rendered. So if we're doing treatment on a patient, we should be documenting at the same time. And finally, number 8, we need to sign and date each note. That way, if there's multiple clinicians that are working on an individual, we can go back to the individual that provided service to ask for clarification if needed.